Welcome to this talk on low-grade serous ovarian cancer, hosted by the Low-Grade Serous Ovarian Cancer Initiative, formerly known as Cure Our Ovarian Cancer, with Dr. Gershenson. My name is Jane Ludeman, and I'm the founder of the Low-Grade Serous Ovarian Cancer Initiative. The Low-Grade Serous Ovarian Cancer Initiative is a global initiative dedicated to radically improving the survival of women with low-grade serous ovarian cancer through research. We facilitate research in Australia, New Zealand, Canada, the United States, and the United Kingdom, in addition to providing information to empower people to make informed decisions about their health care. I'm really excited to announce our speaker today, Dr. Gershenson. Dr. Gershenson is a professor of gynecologic oncology at the University of Texas MD Anderson Cancer Center and is widely acknowledged to be the world expert in LGSOC. His research has transformed the way LGSOC is treated and diagnosed. He is the chair of the International Consortium for LGSOC Research called the ICLC. In 2022, he received the Giants in Cancer Care Award for Gynecological Oncology that recognizes individuals who have achieved landmark successes in oncology in recognition of his extraordinary achievements and commitment to rare ovarian cancers, particularly low-grade serous ovarian cancer. Thank you so much, Dr. Gershenson, for joining us today. Now over to you.
Well, thank you so much, Jane, for that kind introduction and also the opportunity to talk today about my favorite topic, low-grade serous ovarian cancer. So hello, everyone, and welcome. Today, what I'd like to do is give a brief overview of the progress that we've made in the last 2 decades in the study and treatment of low-grade serous ovarian cancer, understanding that progress is never as rapid as any of us would like. But at the end of the talk, I'll highlight 2 strategies that I think will accelerate our progress over the next 5 to 10 years in this field. So these are my disclosures. So as most people know, there are 4 subtypes of epithelial ovarian cancer: clear cell, mucinous, endometrioid, and serous. Serous being far and away the most common subtype, but also understanding that 90% of serous ovarian cancers are high-grade serous, and only about 10% are low-grade serous. So to begin with, what I'd like to do is tell you kind of what the state of the science was in the 1980s, 1990s, and even into the first part of the 21st century. So this is a listing of phase 3 clinical trials of the gynecologic oncology group from about 1981 to 2011. These are all randomized clinical trials for women with mainly with advanced ovarian cancer, although some of them do, I think, address early ovarian cancer, but it's ovarian cancer of all subtypes. During this period of time, there were no clinical trials basically for any of the specific subtypes, including low-grade serous ovarian cancer. And so in each of these trials, you might have 4 or 5% of the patients or women in the trial had low-grade serous ovarian cancer. But because of that, we didn't really learn much about treating some of these rare subtypes because there weren't enough patients in any one of these trials to really educate us. Likewise, during this period of time and even before, there were basically 2 grading systems for serous ovarian cancer. Grading is the microscopic appearance of the tumor, with grade 1 being a more well-differentiated, thought to be more indolent, grade 3 being less indolent, more aggressive types. But there were two different systems. One, and this was a three-tier system, grades 1, 2, and 3. So there was no single universal system. There were no criteria for defining the thresholds between the grades from 1 to 2 to 3. And this led also to significant inter-observer variability in the assignment of grade. In some broad way, we understood early on that grade 1 was more indolent, had a somewhat better prognosis. Grade 3 was more aggressive, but we really had a very difficult time knowing the prognosis of women who had grade 2, and was that even real at the time? And during this period of time, it just tells us that just because you've always done it that way doesn't mean that it's not incredibly stupid. I think, there was a little bit of progress, but I think we could have learned much earlier to divide the subtypes and to study them separately. But this really occurred as an inflection point in the first decade of the 21st century. And these were the highlights that accelerated that progress. In 2003, the Human Genome Project was almost completed, and we were beginning to learn a lot more about the genes and the mutations and the aberrations that occurred in the rare subtypes, including low-grade serous. In 2004, the MD Anderson group introduced the binary grading system for serous ovarian cancer. And so we went from 3 grades to 2 grades, low-grade serous and high-grade serous. But it took another decade before the World Health Organization actually adopted this grading system, and now it's universal. But even between 2004 and 2014, most gynecologic pathologists were beginning to accept this grading system. Then in 2005, the Gynecologic Oncology Group finally established the Rare Tumor Committee. And in that committee, we began to develop clinical trials specifically for women with the rare subtypes and not combining all subtypes into one clinical trial. And that was a real measure of progress. And the first trial really was activated from this committee in 2007. So this is the binary grading system. Low grade, the main feature is mild to moderate nuclear atypia, with a secondary feature of mitotic index that distinguishes low-grade serous ovarian cancer from high-grade serous. We also know that when low-grade serous ovarian cancer is diagnosed, you will find in about 60% of patients, there is also coexistent serous borderline tumor. So that pretty much, even back in the 1990s, we had clues that serous borderline tumor and low-grade serous ovarian cancer were somehow related. And we'll talk a little bit more about that. These are some of the prominent clinical characteristics of low-grade serous carcinoma. I won't dwell too much on this, but it's rare, represents less than 10% of epithelial ovarian cancers. It's diagnosed at a younger mean age, with the median age of 45 compared to around 63 for high-grade serous ovarian cancer. And because of that, fertility preservation is of greater concern in the low-grade serous ovarian cancer population compared to other subtypes. 90% of patients, at least in the studies that have been completed thus far, are Caucasian. We know that low-grade serous ovarian cancer may arise de novo, meaning there's no absolute precursor lesion that we know of, or it can arise following a diagnosis of serous borderline tumor, and that occurs in about 20% of women with this diagnosis. It may originate in the ovary or the peritoneum. About 60 to 80% of the cases are stage 3. So stage 1, where it's limited or confined to one or both ovaries, is super rare. It's maybe 10%, 15% at most in most studies. It's not a major part of the hereditary ovarian cancer syndrome because probably around only 2 to 4% of women who have low-grade serous ovarian cancer have a germline BRCA mutation. We know compared to high-grade serous ovarian cancer, low-grade serous ovarian cancer is relatively insensitive to chemotherapy, but it doesn't mean that it doesn't respond to chemotherapy at all. It just means it's less responsive. And that's a concept that's been a little bit misunderstood, I think, over the last several years. We know that it's also characterized by prolonged overall survival, with the median overall survival in the studies that have been reported in the range of 135 to 150 months compared to high-grade serous carcinoma, where the median overall survival is somewhere in the range of 40 to 60 months. And finally, it's also important to note, though, at least 50% of patients relapse. And historically, we've reported that rate of relapse as high as 70 to 80%. But there may be some good news in that we think with contemporary therapy, there's at least a preliminary sense that the recurrence or relapse rate is less. As far as the biology of low-grade serous ovarian cancer, we know a couple of main themes. One of them is that low-grade serous ovarian cancer is similar to HR-positive breast cancer. And that's very important because over 95% of low-grade serous ovarian cancers are estrogen receptor positive, and about 50% are progesterone receptor positive. We also know that women who are younger tend to have a somewhat worse prognosis than older women at the time of diagnosis. And we also have found out over the last several years that in several different clinical settings, in the adjuvant, neoadjuvant, maintenance, and the recurrent setting, that low-grade serous ovarian cancer responds to a variety of hormonal or endocrine therapies. The other major biology finding in the last 20 years has been that low-grade serous ovarian cancer has a very prominent pathway in its pathogenesis, which is the MAP kinase signaling pathway, the RAS, RAF, MEK, ERK pathway. There are a lot of different terminologies for this pathway. But we do know that this is important for at least some patients, maybe not all, who have low-grade and develop low-grade serous ovarian cancer. So we'll talk more about that. In a study that we did a couple of years ago, and this is maybe hard to read, but we did find that about 50% of low-grade serous ovarian cancers do have an aberration or a mutation in the MAP kinase signaling pathway. The most common mutation is KRAS that occurs in about 33% of low-grade serous ovarian cancers. And then about 10% of them have either a NRAS or a BRAF mutation. And then it really trails off into other mutations, NF1, NF2, ERBB2, so on and so forth. In 2022 and 2023, there were 3 studies that were published that showed pretty identical results. We all found that, as I said, around 50, a little bit over 50% of patients, depending on which genes they included in their analysis, had aberrations in the MAP kinase signaling pathway. And in that last column on the right, you can see that all 3 studies found that patients who had such an aberration did have a somewhat better prognosis in terms of either progression-free survival or overall survival. So when we look at what's been learned in the last couple of decades about low-grade serous carcinoma and prognostic factors the predictability of outcomes, understanding that these apply to a large population of women. It's not meant to tell an individual specifically how they're going to do, because there are many exceptions to this. So even though a patient may not have any of these factors on the left that we think are related to a better prognosis, it doesn't mean that they're not going to do well. And those definite prognostic factors are older age at diagnosis for favorability, lower FIGO stage of disease, having no gross residual disease at the completion of primary surgery, and then, as I discussed a moment ago, the presence of a MAP kinase pathway mutation. On the right are some possible favorable prognostic factors, but they're preliminary because they've been shown in 1 or 2 studies, but they do need to be confirmed. A history of prior serous borderline tumor, peritoneal versus ovarian origin, lower CA-125 level at diagnosis, the presence of extensive pseudomonas calcifications at the time of diagnosis, and a higher progesterone receptor expression level. This is the current NCCN guideline for low-grade serous ovarian cancer, understanding that there are many questions that are unanswered. And much of this is based on a panel of experts, rather than hard data. So for stage 1A and 1B, confined to the ovary or ovaries, the general recommendation is observation. For stage 1C, where there has been rupture of the ovarian tumor, or there's tumor on the surface, or there's positive ascites at the time of diagnosis, you can see that there are 3 options that are given: observation, chemotherapy followed by hormonal therapy, or hormonal therapy alone. Well, and that only tells us that we really don't yet know the best treatment for women who have stage 1C. For stage 2, 3, and 4, the options are pretty much systemic chemotherapy followed by maintenance letrozole or hormonal therapy versus hormonal therapy alone without any prior chemotherapy. And we'll talk more about that and how that developed in a moment. And on this page of the NCCN guidelines, on the left there, you see the recommendation for monitoring, which usually at the first year after diagnosis is every 3 months, second year about every 4 months, and then for years 2, 3, and 4, or 3, 4, and 5 rather, every 6 months, and then annually after that. And on the right there are some of the options for recurrence therapy, and we'll talk more about that in a couple of minutes. So let's talk first about primary surgery for patients who are found to have early stage disease, stage 1. And again, this is only about 10 to 15% of women. So for this group of women, you know, if they're older and they've completed childbearing, it's really the same as for the other stages. And it's hysterectomy, bilateral salpingo-oophorectomy, comprehensive surgical staging, and if there is any evidence or question of metastatic disease, then debulking. But for many young women, fertility-sparing surgery is potentially an option, but it's very selective. We know that stage 1, as I said, is rare. The bilateral involvement of the ovaries is pretty high, at least 50% and maybe higher. And so if you're going to perform fertility-sparing surgery, this is decision-making at the time of the surgery, given that the patient has had optimal counseling about the options that might occur at the time of surgery. Because one of the things that's done or performed at the time of surgery is removal of, let's say, a part of an ovary or one ovary with frozen section to hopefully make the right diagnosis. And then If the other ovary is normal and the uterus is normal in a young patient who has not completed childbearing, those organs can be left in place. Or sometimes it may be bilateral ovarian cystectomy. So it varies a lot from one patient to another. And so patients who do have fertility sparing surgery and have one ovary left or parts of both ovaries, some of them will choose to undergo oocyte retrieval as an IVF procedure after they've had fertility sparing surgery. There are concerns about the risks of the hormonal stimulation during the oocyte to stimulate the oocytes so that they can be retrieved. Although we know from recent studies that if letrozole is given at the time of the stimulation with the gonadotropins, that does lower the estradiol levels and we think reduces the risk. But we don't completely know what the risk is, but we think it's pretty low. And then, of course, there may be risks of pregnancy. And of course, one of the worst things that can occur is if a woman with low-grade serous ovarian cancer does become pregnant and then develops a relapse during pregnancy, that's not a desirable set of circumstances either. But we have had patients who've successfully gotten pregnant, delivered normal children. I just saw one of my patients last week who has a healthy 7-month infant. But fertility sparing surgery for low-grade serous ovarian cancer still remains somewhat controversial. Of course, the principle for women who have stage 2, 3, and 4 disease is optimal cytoreduction to no gross residual disease. That's the ideal. And there are several studies in the literature now in low-grade serous ovarian cancer to show that women who do have cytoreduction to no gross residual are going to have a somewhat better prognosis than women whose tumors are not able to be completely removed. Although even if you can remove, 95%, it certainly is going to be associated with a somewhat better prognosis than if you never had surgery or if you have much higher tumor burden at the completion of the surgery. So that's a very fixed principle that we have. I've already mentioned that, as most people know, low-grade serous carcinoma is relatively chemo-resistant, but not completely chemo-resistant. And there are a number of studies in the literature. Probably one of the better ones is the Grabowski study from Germany, in which they found that patients who had measurable disease following completion of primary surgery, about a quarter of those patients did respond to chemotherapy, platinum-based chemotherapy. In the neoadjuvant setting, it's not been as good. 11% response rate in Dr. Cobb's study from MD Anderson. And then we know in the recurrent setting, the response rates to chemotherapy range from 3.3% all the way up to 13% in studies that we'll talk about in a few minutes. Whereas high-grade serous ovarian cancer in the recurrent setting has response rates in the range of 15 to 30%. So still not great, but better than low-grade serous carcinoma. So in 2017, there were 2 studies that were reported. One from the MD Anderson group, in which 203 patients underwent primary cytoreductive surgery, and then 133 of them were given chemotherapy and then were placed on surveillance, whereas 70 of the women had the surgery, the chemotherapy, and then were placed on some hormonal therapy. And it was a variety: tamoxifen, aromatase inhibitors, Lupron, et cetera. And what we found was that the women who had the hormonal maintenance therapy following the chemotherapy had a much better progression-free survival than women who just had chemotherapy followed by surveillance. We didn't really find a statistical difference in the overall survival, although there has been a recent study that has looks like it does show some improvement even in overall survival. On the right is the Johns Hopkins study from Dr. Amanda Fader, a much smaller group of patients, 27 patients who also underwent primary cytoreductive surgery, but then just received hormonal therapy, no chemotherapy. And her results were pretty equivalent, although they didn't have as much follow-up. They had 3-year progression-free survival, which was about 80%, which was similar to what we found. And so based on those two studies, the Rare Tumor Committee of the GOG developed this trial, which is an ongoing trial, NRG-GY019, for women who have primary cytoreductive surgery and are found to have low-grade serous ovarian cancer, stage 2, 3, and 4, are randomized to either platinum-based chemotherapy followed by letrozole maintenance indefinitely till progression versus just letrozole. This is a study that is scaled for 450 patients. This slide's a little old, so I think about 350 patients, give or take, have been accrued to this study. It'll be about another year before it's completed. But this is a non-inferiority trial. And if we do find out, in fact, that letrozole alone, without prior chemotherapy, is just as effective and associated with the same outcomes as chemotherapy followed by letrozole, that will allow us then to completely abandon chemotherapy in the primary treatment of low-grade serous ovarian cancer. So again, it's going to be about another year and a half, 2 years before we have a signal from this trial, but it's a very important trial. We reported on patients who underwent one of those two treatment strategies, 99 women who had stage 2, 3, or 4 disease, primary surgery, followed by either chemotherapy and then letrozole maintenance therapy versus letrozole or aromatase inhibitor therapy alone. Median overall survival in this group so far was 130.7 months. At the time of analysis, 49 of the patients had relapsed, 50 had not. And it was interesting that of all the patients who relapsed, all of them except one did so before 5 years of follow-up. One patient relapsed in the 6th year. And so far, I know that another patient has relapsed in the 6th year as well. But this study, I think, gives us some clues about how we might see that the relapse rate, I hope, will be reduced from 70, 80% to around 50% at most. A few words about neoadjuvant chemotherapy. Neoadjuvant chemotherapy is not the preferred approach in low-grade serous ovarian cancer. However, there are a small proportion of patients who need neoadjuvant treatment based on extensive tumor burden or comorbidities and the opinion that most or all of the tumor cannot be resected at the primary surgery. And so the idea is to treat it first systemically and then provide surgery sometime after 3 to 6 cycles of treatment. This decision should always be made by a gynecologic oncologist. Unfortunately, we don't have absolute criteria for the selection of patients for neoadjuvant therapy. The only tools we really have are imaging or laparoscopic assessment. So we have a lot to learn in this area. There are 2 studies, however, that have documented that there's been an increase in the use of neoadjuvant therapy for low-grade serous ovarian cancer in the US. And we actually want to see the reverse trend. We want to see fewer patients undergoing neoadjuvant therapy. Our initial study by Dr. Schmaler in around 2012 with 24 patients showed a very small 4% response rate to neoadjuvant chemotherapy. And then, as I mentioned, Dr. Cobb's study a few years ago showed an 11% response rate to neoadjuvant chemotherapy compared to 75% in patients who had high-grade serous ovarian cancer. So chemotherapy is not a great treatment for in the neoadjuvant setting, but we know there's some things we can do possibly to improve that. One of those is to combine chemotherapy with Avastin or bevacizumab. And in the few patients that we've treated in the last few years, we do see improvement in response rates for sure. But there are other strategies that we've explored as well. So this is one of them. It's a pilot study of neoadjuvant fulvestrant, which is an anti-estrogen hormone receptor degrader, combined with what's called a CDK4/6 inhibitor, abemaciclib in this particular study. And so patients received no chemotherapy. They received this endocrine therapy plus a CDK4/6 inhibitor. It was only 15 patients. And what we found was that on the right there is the response rate in this group of patients was 60% compared to the 11% I mentioned in Dr. Cobb's original study with chemotherapy. So this is one strategy that we're trying to explore further with a larger study. We're having some issues finding pharmaceuticals who are willing to do this study, but I think we finally have. And this is one strategy that's used in the neoadjuvant setting. Another strategy that's being studied is a MEK inhibitor in combination with a FAK inhibitor. There's a small study, a neoadjuvant treatment study with that as well. So I think we're seeing progress in this area, but we need to see more. A few words about secondary cytoreductive surgery in the recurrent setting. So there have been 3 large randomized phase 3 trials in ovarian cancer in general that tell us that there certainly may be some benefit to secondary surgery. But again, the problem is there are very few patients with low-grade serous ovarian cancer that have been accrued to those studies. We know if we're selecting patients for secondary cytoreductive surgery, there are certain criteria that many physicians, gynecologic oncologists will use. So obviously, a lower stage at the time of original diagnosis is ideal. Having minimal to no residual disease at the time of the completion of the primary surgery is good. Very importantly, patients who are selected for secondary cytoreduction generally have a limited number of tumor sites, 1 or 2, maybe 3 at the most, not what we call carcinomatosis with small implants spread throughout the peritoneal cavity. Having no ascites is a good favorable factor, good performance status, lower CA-125 level, and a longer platinum-free interval. These are all factors that physicians will look at in trying to best select patients for surgery, because these surgeries can be very long, very complicated, associated with comorbidities and complications. So this is not something to take lightly, but secondary surgery is increasingly utilized in women who have low-grade serous ovarian cancer. These are a couple of studies, the one on the left from MD Anderson and the one on the right from China. We know that at the time of secondary cytoreductive surgery, if we can reduce the tumor down to no gross residual, patients are going to have better outcomes than if we are unable to completely reduce the tumor. Of course, these patients still need further systemic therapy. These are some of the options for the treatment of recurrence or relapse. On the left, you can see the chemotherapy options. On the right, endocrine therapies, most commonly aromatase inhibitors, if patients have not previously received them, fulvestrant, tamoxifen, dipolupron, with ideally the addition of a CDK4/6 inhibitor based on the neoadjuvant study that I showed you and a study I'll show you in a moment. The problem there is that these CDK4/6 inhibitors are not FDA approved in the US. Some patients are able to gain authorization based on their insurance, third-party payers, others are not. But we do believe that it does enhance the activity or the effectiveness of the endocrine therapy. And so when we look at the experience with endocrine therapy in patients who have recurrent low-grade serous carcinoma, both in the retrospective studies that we published early on and in the clinical trials, the response rates to letrozole or anastrozole are very consistent, 13 to 14%. That's true in the retrospective studies, and in the two prospective studies, GOG 281 and the Paragon study from Australia with anastrozole, 14%. A very high stable disease rate, and sometimes patients will have a response or stable disease for long periods of time. This is GOG 3026 that was reported at the SGO meeting a couple of years ago. This was a study in which patients with recurrent low-grade serous ovarian cancer who had not previously received letrozole for this diagnosis received letrozole and the CDK4/6 inhibitor ribociclib from Novartis. And the primary endpoint was response. And there were about 51 patients accrued to the study. 48 of them were evaluable. And what we found was the vast majority of patients had either stable disease or responded. And the response rate at the time it was reported at the SGO meeting was 23%, although we've recently reviewed the data, or actually are in the process of that. And we think, although I don't have a fixed number for you right now, I believe the response rate's going to be well over 30%, but I'll know that better in a few weeks. But that's an important study. And I think once this is published, hopefully it will, CDK4/6 inhibitors will be FDA, well, not FDA approved necessarily, but will be on the compendium and much more accessible for patients. I mentioned bevacizumab or Avastin in the treatment of low-grade serous carcinoma. There are two retrospective studies, one from Memorial Sloan Kettering and the other from our group at MD Anderson, that showed very high response rates to bevacizumab, usually in combination with chemotherapy, but sometimes even as a single agent. And so this is an active agent and needs to be utilized more broadly in the overall treatment of low-grade serous carcinoma, I think in the primary setting as well as in the recurrent setting, in combination with not only chemotherapy, but with endocrine therapy and possibly MEK inhibitors. Then there was a phase 2 study that showed a 15% response rate to the MEK inhibitor selumetinib, which led to two second-generation studies, the Milo study, which was a randomized phase 3 study of the MEK inhibitor benimetinib versus physician's choice of chemotherapy, pegylated liposomal doxorubicin, weekly paclitaxel or topotecan. And unfortunately, that study did not show any difference in the progression-free survival of patients. However, we believe that that was because their patient population was not heavily pretreated. And so the standard of care cohort actually outperformed what was predicted. And because I think benimetinib is an active agent. The Milo study, the GOG 281 study was a very similar design, phase 3 randomized between trametinib, another MEK inhibitor, versus same chemotherapy drugs, but we also added either tamoxifen or letrozole to the standard of care options that patients had. This was a trial for 260 patients, and we did actually find this was a positive phase 3 trial. The progression-free survival median was 13 months for trametinib versus 7.2 months for the standard of care cohort, and the response rate to trametinib was 26% versus only 6.2% for the standard of care. So this was a positive study and led to the approval of trametinib being added to the NCCN guidelines, which made it, certainly in the US at least, more available for women with recurrent low-grade serous ovarian cancer. Then, of course, there was the RAMP 201 study that followed the FRAME study, which was a different MEK inhibitor. It's actually a RAF MEK inhibitor combined with a FAK inhibitor. This is from the Veristem group. And this study did show also a very good response rate. They studied these as monotherapies, as the combination, and also studied patients who had KRAS mutations as well as patients who had wild-type KRAS. And what they found was that the response rates were 45%, higher in the KRAS mutant women tumors, 60% versus only 29% in those women whose tumors were wild-type KRAS. If you look at the results of the GOG 281 trial, we actually analyzed it for patients who had KRAS, BRAF, or NRAS mutations. The response rate was 50%. So the results of this trial look promising. This is going to be reported out in detail at the upcoming International Gynecologic Cancer Society meeting in Dublin later this month. And this trial, of course, led to the RAMP 301 trial, which is an ongoing randomized phase 3 trial of the combination of avutometinib and defactinib versus, again, physician's choice chemotherapy of either pegylated liposomal doxorubicin or weekly paclitaxel, or I believe letrozole is another option. And so that is an ongoing trial. We've learned I'd say just in the last few years that the FDA did approve a combination of trametinib, a MEK inhibitor, and a BRAF inhibitor, dabrafenib, for women whose tumors have a BRAF V600E mutation. We know, as I've mentioned, about 10% of women with low-grade serous ovarian cancer do have this mutation. So if they do recur, this would be the first, I think, the first treatment to use this combination in those women with the BRAF mutation who do recur. You probably have heard of Elahere or mirvetuximab, which is a drug that's a folate receptor antibody. It's an antibody-drug combination that was studied only in women with high-grade serous ovarian cancer. It was approved by the FDA several months ago, but now it is available, at least in the US, for women who have recurrent ovarian cancer with a positive folate receptor with expression of at least 75% of the folate receptor alpha. We know that from recent studies that have not yet been published, that about 25% of women with low-grade serous carcinoma also will have a positive folate receptor. So this is definitely an option for those women. And I just saw a patient 3 weeks ago who's being treated with mirvetuximab for recurrent low-grade serous carcinoma, and she's responding very well. Then this is just a listing of recently completed studies. It includes the Paragon study I mentioned from Australia, the RAMP 201 study from Veristem that will be reported later this month in full, and then some other studies combining MEK inhibitors with PARP inhibitors, MEK inhibitors with PI3 kinase inhibitors, so on and so forth. And then these are some ongoing studies. The Fuchsia study has been recently published. It was only 15 patients. There were 4 women with low-grade serous ovarian cancer treated with fulvestrant. All 4 of them had stable disease, but none of them responded. And then there's some of these other trials that are ongoing, again, combining letrozole with a CDK4/6 inhibitor, a different combinations of a MEK inhibitor and CDK4/6 inhibitor, so on and so forth. There are a couple of immunotherapy studies listed here, and I know there's some questions about that I'll try to answer. And so while we've made, I think, a good deal of progress in the last 2 decades, there's still many, many questions remaining. I won't read all these, but just there are a lot of areas where things are not at all clear to us. And we need more trials, we need more study in order to learn more about how best to care for women with low-grade serous ovarian cancer. So I think, as I said, I think there are two strategies that are going to take us into the next 5 to 10 years. And this has to do, first of all, with the partnership of large patient advocacy groups, such as the one Jane leads, the STAR Ovarian Cancer Group in the US, and others. Overcome is another broad ovarian cancer group, in collaboration with physicians and scientists who are focused on the study and the treatment of patients with low-grade serous ovarian cancer. And I think there's much that can be done and accomplished in this partnership in advocacy, particularly with the FDA, with pharmaceuticals, because it still is very, very difficult for us to obtain drugs to study in a rare cancer. I can assure you. And the pharmaceuticals are reluctant in many cases to do that, although I think it is loosening up, and I do have a lot of hope for the future. And then the other strategy, which is a little redundant, is to develop an international consortium of physicians and scientists, experts in the field. Jane's family triggered the organization of this group, which is the ICLC, which now includes 25 physicians and scientists from 7 different countries. And I think this group is going to make a great impact on the study and progress in the field of low-grade serous ovarian cancer. There's some very excellent individuals here. There are a couple things just to give you some idea. One of the projects is a collaboration with the Global Coalition for Adaptive Research, which is a nonprofit organization. And we've been working hand in hand with this organization for the last couple of years to develop this platform trial strictly for patients, for women with low-grade serous ovarian cancer with recurrent disease. And on the left, you can see there can be a series of phase 2 trials going on simultaneously with or without a control arm. And then if we see a signal, we can move that into the right-hand side with a phase 3 trial to get accelerated FDA approval for new drugs. We are already negotiating with 2 pharmaceuticals that have drugs that are of great interest and seem to be very applicable to the treatment of low-grade serous ovarian cancer, and I'm sure we'll see more. We just submitted our report and white paper to the FDA that's been reviewed. We had a session with them last week, and we hope to be able to activate this platform study with multiple simultaneous trials for low-grade serous ovarian cancer sometime in at least at the longest, I hope, the second quarter of 2025. So I'll end with this saying from Emily Dickinson: hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all. So again, thank you very much for your attention. I hope this has been helpful. I want to thank all the patients and the families, because all of us learn from patients. They're our best mentors. And if it weren't for that, we would not have made the progress we've made so far. And of course, I want to thank all of the patient advocacy organizations that work with us in partnership. So thank you very much. And I'll stop there, and I think Jane is going to have some questions. I think you're on mute, Jane. Yeah.
Thank you so much for that excellent talk that just covered so much interesting information. I think for me, I interviewed you first in 2019, and it's just really incredible to see how much progress has been made and how many different and new treatments are being talked about that weren't around back then. So that's really great to see. So we've had quite a few questions, both through the Q&A chat, but also submitted in advance, and people can continue to submit questions through the Q&A as well. So I'll just go through some to start off with. Looking at the risk factors for low-grade serous ovarian cancer, do we understand why people get low-grade serous ovarian cancer? What makes someone more at risk of developing it compared to someone else?
Yeah, so as I answer these questions, I'll preface it by sometimes I'll say I have no idea. Sometimes I'll say maybe, and hopefully some of these we can answer fairly definitely. Well, we do have some clues for this question, but they're clues. So we know there was a Danish study of women who had serous borderline tumors, which we think is a precursor in many cases, if not maybe most or all, to low-grade serous ovarian cancer. And they compared those women with serous borderline tumors to a cohort of controls, several hundred women. And what they found was they found two risk factors that seemed to be associated with the development of a serous borderline tumor. And those two were infertility, history of infertility, and probably in older women taking hormone replacement therapy like estrogen. And those two factors definitely were associated with a higher risk of developing serous borderline tumor, and we think may well translate into a risk for low-grade serous ovarian cancer. I've also, as I mentioned in my talk, this is not part of the hereditary ovarian cancer syndrome. So BRCA mutations are very infrequent in this. So we don't think this is, at least based on the information we have, that it's inherited. But beyond that, we really don't know what causes this disease. And hopefully we will learn that in the next 10 years or so.
And so on that, you did mention that a lot of the patients are Caucasian. Do we have any understanding of the factors that make certain ethnicities more predisposed?
We don't. We do know that in most of the studies, 90% of women are Caucasian. We see Black, Hispanic, Asian, but we don't. In some of the other rare tumors, like malignant ovarian germ cell tumors, for instance, we know that Latin American women, Hispanic women, and Asian women are more likely to develop malignant ovarian germ cell tumors. But we don't really, have any preliminary information that tells us why it seems to be mainly Caucasian women.
Thank you. And moving on to the pathology and genomics of low-grade serous ovarian cancer, you mentioned earlier in your talk about, now I'm not going to be able to say this right, somatis calcifications at diagnosis being potentially linked to improved diagnosis. Is that the same as when people talk about calcifications developing after diagnosis and treatment, and what are the implications of calcifications for prognosis, recurrence, and treatment?
So we don't know a lot. What we know, so we have a preliminary information, as I briefly mentioned in my talk, that and this is very preliminary, it needs to be studied further, that if when you review the histology, the pathology from the patient's primary surgery, if they seem to have extensive semogenous calcifications, that there's a hint that they may have an overall better prognosis. Now, we know that low-grade serous carcinomas not infrequently do have calcium in the tumor implants. We don't know why. We don't know what causes that. We think it treated over time. If the calcium seems to be increasing, possibly the tumor cells are decreasing, and that may be a good prognostic factor, but there's still a lot to be learned here. So we don't know what causes the calcium buildup. We believe it could be a good factor, but we don't have a definite read on that as of this point in time.
Thank you so much for that. And now moving on to P53 mutations. So most low-grade serous ovarian cancer, as far as I understand, has wild type P53, which means unmutated. What proportion of low-grade serous ovarian cancer has mutated P53, and does that affect treatment?
Yes. So many experts believe that 0% of low-grade serous ovarian cancers have a P53 mutation. In fact, that's one of the tests that may be done to confirm the diagnosis of low-grade serous ovarian cancer. I personally believe that probably less than 5% may have a P53 mutation, but that's not shared by many other experts. And so I would say the dogma right now is that it's 0. It doesn't really affect treatment at all. There are drugs that out there that indirectly target P53 mutations, but they're not really relevant since low-grade serous carcinomas essentially don't have these mutations. Now, there's also a family of drugs that actually seem to be more effective in tumors that have P53 wild type. And one of those drugs is a target for this platform trial I mentioned briefly for the GCAR ICLC collaboration. And we have a lot of interest in studying that drug in low-grade serous ovarian cancer.
Thank you so much for that. Now, just to move on here, are you able to explain, so when we talk about KRAS and BRAF and their MAP kinase mutations, how is it that someone's cancer can have these mutations, but the other cells in their body don't?
Yeah, well, it's just a difference between what we could call germline mutations and somatic tumor mutations. So these are only mutations that occur in the tumor. They're not in every cell in the body. A good example of a germline mutation in which every cell of the body is affected are the BRCA mutations, BRCA1 and BRCA2. Those can be either germline mutations affecting every cell in the body, or they can be just tumor mutations like KRAS, BRAF, and NRAS. So it's only affecting the tumor. It's not a mutation in all of the cells of the body.
That's really helpful, thanks. And someone else had quite a specific question that I'm not sure about the answer with, so it'll be interesting for what you say. They were curious on their pathology report about PAX8 and whether that's something that's common in low-grade serous ovarian cancer.
Yeah, PAX8 is a protein that's very ubiquitous in gynecologic tumors, endometrial cancer, and ovarian cancer. It's used primarily by pathologists to stain the tumor to confirm a diagnosis. And it can be, it's not just low-grade serous carcinoma, it can be high-grade serous carcinoma, much less common in mucinous carcinoma of the ovary. There are some early studies in trying to develop drugs that target PAX8, but those, to my knowledge, are very early, and I haven't seen any trials yet with that. But it's mainly used as simply as a diagnostic tool because it's expressed very commonly in, particularly in serous carcinomas.
Right, and someone else had a question wanting to just understand a little bit more about the connection between borderline tumors and low-grade serous ovarian cancer, if you have anything more to add to that.
Well, I don't know if I have anything more to add. In our studies in the 1990s, if a woman has a serous borderline tumor and it's confined to the ovary, it's stage 1, we think her risk of having any further problems is exceedingly low, less than 1%. The problem is in women who have a borderline tumor of the ovary, but also have these borderline implants within the peritoneal cavity, mainly in the omentum or on the peritoneal surfaces. Those women, we think, have at least a 20% lifetime risk of subsequently developing invasive low-grade serous ovarian cancer. So that's another connection. I mentioned that when low-grade serous ovarian cancer is actually diagnosed, 60% of the tumors also have serous borderline tumor. So there are a lot of connections there. That's about the extent of what we know right now, though.
Thank you so much for that. And someone else just had a quick question, I think, for a clarification, that if someone's wild type P53, they can still have other types of mutations. That just means that this P53 specific gene isn't mutated.
Yeah, that's right. That's right. You can have, when you do what we call next generation sequencing or what we call genomic profiling, somatic tumor testing, it's all the same thing. You're testing a panel of 400 mutations, 500 genes rather. And yes, you can have some tumors have multiple mutations, not just one. Some have none, and some have only one. But yeah, of course, you can, even if you do not have a mutation in P53, you can have mutations in other genes, yes.
Thank you for that clarification. And now moving on to hormonal therapy. So you talked about anastrozole and letrozole in the context of recurrence. Do you think that overall the aromatase inhibitors, anastrozole, letrozole, and exemestane are equivalent, or is there a feeling that one might be better than another?
Great question. We don't have enough information to absolutely know. Here's what I think we know. And that is, it is true that letrozole, at least in the US, letrozole has been used much more extensively than anastrozole, but both have been used. I think anastrozole and letrozole are pretty equivalent. I don't think we have any information to suggest that they're not. The Paragon trial from Australia showed the 14% response rate. Studies, retrospective studies and trials with letrozole, 13, 14%. So I think those are equivalent. Exemestane is thought to be a more potent aromatase inhibitor. All of these drugs, of course, have been studied much more extensively in breast cancer than they have in low-grade serous. But whether it provides any advantage, we don't know because it hasn't been studied very well. If a patient is on letrozole or anastrozole and they do develop a relapse, we would tend not to ever retreat them again with those drugs. But I will occasionally treat a patient with exemestane, thinking that maybe a small percentage may benefit from it because it may have a little bit different properties. So I think it could be a little bit different than the other two, if that answers the question. But we haven't done enough study of exemestane to really have a good sense.
Thank you. That's really helpful. And this has been a very popular question that people wanted to know. If someone is on aromatase inhibitor maintenance and the treatment is working for them and they're remaining no evidence of disease, NED, how long what's the recommendations around how long someone should stay on that treatment? And does it vary depending on whether they're stage 1C or stage 2 to 4?
Also a great question. I'll take the last part first. We don't really know about the difference in stages. Should the recommendation be different? Although there certainly is a sense, I think, among experts that it could be different. Right now, I think, as many people know, if you start a aromatase inhibitor either after chemotherapy or without chemotherapy previously, the recommendation, and this came out of a 2022 International Consensus Conference of 25 experts. The recommendation is to take it indefinitely, which could translate into the rest of your life, as long as you're not, of course, if you develop a relapse, you need to change treatments. But if you don't develop a relapse, then the recommendation right now is indefinitely for the rest of your life. I believe, because I gave you a little bit of data, that there's some preliminary evidence that if a woman has not developed a recurrence by 5 or 6 years, I can't say it's zero, but the risk of relapse at that point may be exceedingly low. My hope is that in the not too distant future, we'll be able to cap it at maybe 10 years. Breast cancer initially, when they started using hormonal therapy, they were recommending 5 years. Then in many other studies, that extended to 10 years. So I would say right now, I have to say the party line is indefinitely, but I'm really hopeful that we can limit that in women who are doing well after 5, 6, maybe after at least 10 years. We understand very well that aromatase inhibitors that's not trivial. There are lots of potential side effects, the joint pains, the osteoporosis, the hot flashes, et cetera, et cetera. Of course, for those listening who don't know it, Veoza is a wonder drug now for hot flashes, but very expensive and not always covered by insurance. Effexor is the other drug. But so we understand the quality of life can really take a hit with aromatase inhibitors. And so that's why I'm so hopeful that we can at some point limit it.
Thank you for that. And that's a really great segue into the next area, which has been a lot of interest for people around, because a lot of people do really struggle with those side effects. And so some people have been asking about what's, I guess, the guidance, including, I guess, the risks of taking a temporary break from an aromatase inhibitor because of the side effects, and whether how long someone's been on it would influence that recommendation, that guidance.
Yeah, that's a really difficult one to answer because we don't know the answer. I think an extended break is probably not a good idea. If somebody wants to take a break for 2 or 3 weeks, I'm not overly concerned about that. But it's tough. I do know one of the things that we found, which has not really been reported maybe at all, or very much, is that women who are on letrozole who are having a lot of problems with joint pains, if you convert them to anastrozole, not all, but many of them will have relief from the joint pains to some degree. I mentioned the drugs Effexor and Veoza for hot flashes. So I don't know. We just don't know what to think of breaks, and it's not is not going to generally be recommended for any extended period of time because there's concern that that may result in cell growth and a recurrence. Those, I guess, would be there was one other thing I was going to mention that I forgot. If I think of it, I'll mention it. But that's kind of where we are right now. It's hard to know.
And I've got another really tricky question for you. If someone along those lines, the situation for people who've had fertility sparing surgery, so what's the consideration around stopping treatment temporarily, either because they want to undergo egg retrieval, or they're interested in carrying a pregnancy? And how would the stage at diagnosis affect that recommendation?
Well, it's usually going to, most of the time, it's going to affect only women with stage 1. Although I have had a couple of patients with stage 3 disease who have had fertility sparing surgery and have had a normal pregnancy. So the recommendation, though, is what do you do if you're, let's say, you're on letrozole following surgery or following surgery and chemotherapy, you still have either an ovary and a uterus, let's say, and you want to get pregnant at some point. First of all, generally, and this is completely arbitrary, I'm recommending that they not get pregnant before they've taken letrozole for at least a year and probably better 2 years, although that may be based on what their age is at the time of diagnosis. Secondly, if they're on letrozole and they want to get pregnant, what the recommendation we know is extrapolated from data from breast cancer patients. The recommendation would be to stop the letrozole for 3 months before attempting pregnancy. Then go ahead and do that. So you're going to be off. And of course, if they get pregnant, either with implantation of embryos or naturally, then of course they will stay off letrozole during pregnancy. And then once they deliver postpartum, they would restart the letrozole. That's at least what we're doing right now. And I just saw a patient with a healthy baby that did just that. So that is currently what we're doing.
And can I just clarify there, when we're talking about going on letrozole, because these are patients who have one normal functioning ovary, what's the treatment that you use in them alongside letrozole when they are on letrozole?
Yeah, so that's a dilemma because letrozole affects the extraovarian peripheral conversion of androgens into estrogens, androstenedione, and this occurs in the fat tissue. And so that's the way you inhibit the enzyme aromatase to reduce the amount of estrogen circulating. It does infect the ovary somewhat, aromatase inhibitors, but not completely. So the other drug that's typically considered and recommended in women who have an ovary is a GnRH analog. So depolupron or gaserolin are the two drugs that are commonly used. The problem there is, how long, that's hard to keep them on both drugs for a long period of time. And so I've talked with our reproductive endocrine and fertility experts about this. Nobody knows how to manage this. Arbitrarily right now, I think unless we learn more about it, I would recommend both drugs, but at the end of a year, I would stop the GnRH analog. and continue the letrozole until which time they decide to get pregnant. And because I think letrozole does have some influence on the suppressing the production of estrogen in the ovary, but the drug that really does it is the depolupron or gaserelin. Whether endogenous estrogen is as bad as exogenous estrogen, we don't really know. But I think, again, it's very difficult to ask patients to take both drugs for an extended period of time.
Thank you for that. And can I clarify, is that just in the circumstances of someone considering fertility and pregnancy, or are you talking about it in terms of the long term if someone's had fertility sparing surgery and they go on an aromatase inhibitor like letrozole and also the treatment to put them into medical menopause? Are you saying that the medical menopause treatment would only be for a certain time, or is that specific to the context of pregnancy?
Well, it's generally specific to women who are young, want to have childbearing.
Mm-hmm.
That's true. I think it's difficult because older women are going to, at least at the time of initial diagnosis, have both ovaries removed. And even, of course, there's an opportunity, even if they have one ovary removed, let's say they complete childbearing, what do you do? There is an elective surgery then to go ahead and have the other ovary removed. That's a personal decision that has to be discussed with the physician. But yeah, again, how long we use these GnRH analogs is an unanswered question right now. And
Thank you. Thank you very much for that clarification. And just one last question on hormonal therapy at the moment. Someone was just curious to know then, in terms of taking the letrozole and anastrozole, are you able, is it assumed, if they are quite similar, that someone could switch between them to try one and see if it's better for their side effects and then switch back to the other one, hopefully without consequence?
Yeah, I think that's not unreasonable. Most patients are not switching back and forth. They're either going from one to the other. But yeah, I mean, even that switching, let's say you're on letrozole, you go to anastrozole because of some side effects, it makes no difference, and you want to go back on letrozole, I think that's fine. Again, I think we consider them to be pretty equivalent.
Right. And now moving on to recurrence. Because obviously now, I guess it's good that we have a lot more treatment options for recurrence, though the availability of each one does differ depending on where people live. But can you tell me, how, as a clinician, do you decide what treatment to give someone in recurrence and the order of those treatments?
At the 2022 International Consensus Conference, all the experts agreed we have no idea how to sequence these agents. We have a menu of all these options. We try our best to pick, and first of all, an option that would be a little, more effective option. We also, of course, have to consider side effects and discuss that with patients. But it's a very difficult decision, and there's no clear answer, because as most women who develop recurrence are going through multiple different lines of treatment. Do we know if it matters whether they have treatment A before B before C, or could they have C before B before A? It may not matter. These are questions that are just right now unanswered. I think if somebody has a MAP kinase mutation in the tumor, you're going to be maybe a little more likely earlier to give them a MEK inhibitor. There also is the thought that because intestinal obstruction may occur late in the course, sometimes using Avastin or bevacizumab earlier is better, because you don't want to give bevacizumab to somebody who's having some issues with partial bowel obstructions, because 2 to 3% of women can develop an intestinal perforation with this drug, and the risk is higher if they have a partial bowel obstruction. So there are those kinds of thinking, but it's just beyond that. It's really, right now, it's difficult. I think we'll learn more about it, but as you can imagine, and it's such a rare cancer, trying to do trials that sequence these things is not easy. Of course, what I would also say in ending in this question is, if there's a good clinical trial available, that for many of us would be the first thing that would be discussed, at least, and considered. So that may take precedence over all of the other standard therapies that are available. But that, again, is an individual decision that patients and their doctors will make.
Thank you. And now you talked about the considerations around surgery for recurrence and mentioned that longer platinum-free interval was one of the decisions factors. Do you think that holds generally, in the sense that not everyone is having platinum based chemotherapy in the first instance, i.e., is it time to recurrence generally, or do you think that recommendation was specific to platinum-free chemotherapy?
Well, there's no one of the factors that I mentioned that is taken in isolation. I think, yeah, you're right. And some women never receive platinum. But if somebody has received it, certainly the longer the interval to recurrence, we think, is one factor that's better, that's favorable. But the other factor, I think if you wanted to look at one factor that's a predominant, it's how many sites of disease are there. So is there a solitary mass either in the abdomen or even in the chest? Or are there multiple implants? I think that's probably the biggest factor that most gynecologic oncologists consider. But we look at all of them together. How did their primary surgery go? Do they have ascites that may not be such a favorable factor, things like that. But I wouldn't over stress the platinum-free interval too much.
Thank you, that's helpful. And this has been a question that a few people have asked as well, just wanting to understand more about the recurrence rates for low-grade serous ovarian cancer by stage. If you can elaborate on
Well,
that.
yeah, so because stage 1 is so rare, we don't have a good read on the recurrence rates, I would say, right now. We certainly believe it's much lower than for stage 3, number one, but we really don't have a number. And also, somebody can be diagnosed with what is thought to be stage 1. Maybe they didn't have an optimal surgery with all of the biopsies. It should have been comprehensive staging at the time of the first surgery. And they recur, and did they really have stage 1 to begin with? As I mentioned, for stage 2, 3, and 4, historically, the recurrence rates have been reported at 70 to 80%, but I'm really hopeful that the preliminary information we have will lead us to, in a few years, understand better that the recurrence rate is decreasing, and it may be as low as 50% in women. So, because most women are receiving contemporary therapy, surgery, followed by either chemotherapy and then hormonal therapy with letrozole or aromatase inhibitor, or surgery followed by an aromatase inhibitor. And I'm hoping that the preliminary evidence bears out and the relapse rate's no higher than 50% and maybe getting lower even. So we have to stay tuned for that, but that's kind of where we are right now.
And I think sometimes there can be a little bit of confusion about this, because we obviously talk about sometimes survival and progression in regards to time periods. But when we were talking about recurrence rates, we're talking about overall recurrence, aren't we, in terms of the proportion of people that we think who don't experience a recurrence, that hopefully then they are cured and get to live a normal life expectancy. Is that right?
Yeah, if I'm understanding your question correctly, yes, we are curing some patients.
Mm.
Also remembering, this thing about median overall survival. What that means, I always tell patients, that means that at that median, whether it's, let's say it's 150 months, 140 months, that means half the patients have not survived. The other half have beyond 150 months, and certainly some of those patients are cured. So that's you kind of again, you have to look at it from a population standpoint. I don't know if did that
Mm.
help to answer your question? Yeah, so I think you have to this median, you always have to remember that half the patients are doing better than the median, whether that's progression-free survival or it's overall survival.
Thank you for that. And now just moving on to some other treatment questions that people had. Someone was interested in the effectiveness of radiation in low-grade serous ovarian cancer and the considerations around its use.
So I'm definitely old enough to remember that in the 70s and 80s and even into the 90s, radiation for ovarian cancer in general was used pretty extensively. With whole pelvic radiation, what was called abdominal or abdominal strip radiation. And that led to a very high rate of bowel obstructions from fibrosis from the radiation that sometimes could be lethal. That we stopped that pretty much in the 90s, and the better chemotherapy took over. Radiation in the treatment of low-grade serous ovarian cancer in today is very limited, but there is a role for it. So I'll give you a few examples. One would be if somebody has metastasis to the bones and if they're having pain, could be the spine, could be another bone. Uh, Spot radiation to that area can certainly relieve the pain. Another area would be if there's a tumor in the vaginal area that leads to bleeding. Radiation may definitely be considered for that. A third area would be if, and this is rare, of course, fortunately, is if a woman develops a brain metastasis. Radiation and the types of radiation have evolved are much better than they were even 10 years ago. So brain irradiation may be considered. But overall, and the fourth example I'll give is sometimes lymph nodes are radiated. It's usually one or a small group of nodes in one area, not extensively if somebody has multiple lymph node metastasis. But that would be a fourth example of the use of radiation, but it is pretty limited.
Thank you for that. And now just can you help us understand? So obviously, we now are seeing some treatments targeted towards the MAP kinase pathway, and some people do have mutations specific to that pathway. But also, when you talked about the results of the trial, we do see that some people can respond to MEK inhibitors even if they don't have those specific mutations. Do we understand why that is?
No. Well, it certainly could be pathways that are somehow interacting with the MAP kinase signaling pathway. We also know there can be what some people consider to be not what they call canonical mutations in the MAP kinase pathway, but associated mutations. So mutations like NF1, ERB2, a few others. There may be some linkage, some affiliation, some relationship between those genes or mutations and the MAP kinase pathway. But honestly, we don't yet have a good understanding of that and know why patients who don't appear to have a classic mutation in the pathway can respond. And that's why we never, patients without any mutations are always going to be candidates for a MEK inhibitor. or for a clinical trial like the RAMP 301 trial, because we are just learning about this, and we know that patients without mutations can respond.
And I have another, probably along the lines of the P53, another tricky question. For people who are ER and PR negative with low-grade serous ovarian cancer, what is the primary treatment recommendation? Are hormonal therapies still used, and what are the considerations and recurrence for that? Do we know how to treat that well?
Well, patients who are ER negative with low-grade serous carcinoma are exceedingly rare. In fact, I'm not sure I can say I personally have seen a patient without some positivity in the estrogen receptor. If you see that, even in high-grade serous ovarian cancer, the estrogen receptor is frequently positive. So it's almost unheard of, first of all. Second of all, if we saw that, I think, are we making the right diagnosis? Is this really low-grade serous carcinoma? There are these rare events, patients who have both low-grade and high-grade serous carcinoma at the same time in the same tumor. And those, they're very rare. We're actually in the process of starting to study that as we speak. But some of those patients, for instance, I had a patient like that recently who was on letrozole following surgery and fairly quickly recurred, was placed on platinum paclitaxel chemotherapy along with bevacizumab, and had an excellent response. And that was probably because the high-grade component might have been more predominant. But that's about the best answer we have right now.
Can you please talk through the management and prognosis, how it differs with someone with a serous borderline tumor with invasive implants compared to low-grade serous ovarian cancer?
So according to the World Health Organization in 2014 and beyond, we now believe in general that invasive implants are the same as invasive low-grade serous carcinoma. So if patients have what used to be called invasive implants, they have low-grade serous carcinoma, we treat them the same as low-grade serous carcinoma. Now, there is a belief, particularly among some of the Europeans, that they're not the same thing. And I think this needs further study. I think so. Because usually invasive implants are very tiny. They're either microscopic or they're 1 or 2 centimeters for the most part. And we historically in the 80s, 90s, early 2000s, we called those invasive implants. Whereas when we see other patients who have low-grade serous carcinoma, they have very extensive tumor, not just small implants. So there could be a difference, certainly, in the prognosis. And are they really the same thing? Again, according to most of the experts, yes, we treat them the same, but I think we do need to further study this to see if there could be a difference, or is it just simply a difference in the tumor burden and the fact that invasive implants tend to be smaller and patients generally do a little better than patients who have more extensive low-grade serous carcinoma. But right now, they're considered to be the same.
Thank you. Now, this is also something that's had a lot of interest. You did reference the NCC guidelines in your talk about this, but can you just specify what your recommended maintenance follow-up for low-grade serous ovarian cancer is, including CA-125 blood tests and scans?
Okay, so my personal recommendation, which is generally in sync with most other physicians, would be in the first year following diagnosis, a patient is let's say they go on letrozole. Of course, if they get chemotherapy, they're going to be seen every 3 weeks initially, and then, but after that, it would be once every 3 months. They would have a physician visit with a scan and a CA-125 every 3 months for the first year. The second year, everything is going in the right direction. They're doing well. Once every 4 months. Years 3, 4, and 5, every 6 months. Physician visit, scan, CA-125, and then once a year. Some patients, though, even at 5 years, don't feel comfortable just coming back once a year, and I don't blame them. And they want to come back still twice a year, for instance, at least. That's most physicians follow that. Not everybody, though. And unfortunately, I see a fair number of women for second opinion whose physicians have, not done a scan for 9 months or a year following the original diagnosis. And that's because they're just not knowledgeable enough about the disease. And can even be true about subspecialists. So these would be the general recommendations that would be followed.
And is there a preference in regards to the scan regarding like CTs versus PET CTs versus MRIs?
There has been a study that's been done, and in that they compared PET CT to CT, and they found that there was no difference in the sensitivity. That's number one. Number two, we all know that PET CTs are more expensive than CTs, and some insurance plans in the US at least don't want to pay for it unless there's a really good reason. One of the main indications, well, let me back up. So in our practice, we generally do CT scans. We think they're as good as PET CT scans in general. Now, there are many physicians or centers where they just routinely do PET CT scans for whatever reason. And that's okay. There's nothing wrong with that. One of the main indications for a PET CT in a patient who's been having CT scans is if their CT scans are remaining normal, but the CA-125 is significantly rising, and you can't figure out why there's a discordance between those two things, that would be a really good indication for a PET CT scan, because it's a different modality. You're looking at the FDG avidity in addition to just size. And so that would be a good indication. But for the most part, most people are doing CT scans. This also has been discussed in International Consensus Conference, and I think that's true of most experts. But there are places where patients are receiving PET CTs on a routine basis.
And following on from that, do you ever permanently say goodbye to your patients if they're doing well? Is there a certain time where you would discharge someone?
Well, yes. I think it's always difficult. It depends a lot. It's an interaction between the patient and the physician, because what I find is a lot of patients don't want to. Well, first of all, we follow patients of all types. So I may see a patient for a second opinion and never see her again. I may see a patient for a second opinion and she wants to receive all of her treatment at MD Anderson, although she may live far away. We see lots of patients who come for a first visit and then they're seen for their scans. So they come every 3 months, first year, et cetera, et cetera. And then so it's all different types. But let's say at the end of 5 years or 6 years, they're doing well. They always have the option to revert to a local oncologist. But so in my view, it's a patient decision. And it's all based on their comfort level about what they want to do. They can do all of those things. I would say most of our patients continue to be followed by us at some level, though. And that's because of their desire to do that rather than we're saying you have to do this. We're not.
In speaking more generally, I guess, when would you, like, is there a point where someone can be safely discharged from all follow-up and care, or do we not know when that point is yet?
I don't think we know when that point is yet for low-grade serous ovarian cancer specifically, of course, with this, that's what we're talking about. I don't think we know, but I think eventually it may well be that certainly after 10 years, somebody is completely normal, normal, no evidence of recurrence, probably at that point, maybe after 5 or 6 years, but we're just not there yet. So it's not something that's at the top of our list right now.
Thank you. And I'm just mindful watching the time that we're going to have to wrap up very soon. So I just have two more questions for you. The first is what are you the most excited about looking forward on the horizon with low-grade serous ovarian cancer and where it's going?
Well, of course, everybody on this call knows one of the greatest unmet needs is the small number of treatments. Even though we've made progress, we still have a limited number of treatments. Pharmaceuticals are still reluctant to fund clinical trials for a rare tumor. But that's why I'm advocating for the patients and physicians and scientists to get together to advocate more robustly for new drugs. But I am excited about this collaboration that the ICLC and GCAR have in terms of platform trials that are occurring simultaneously, concomitantly. I think that's really going to make much more progress and much more rapidly than we've seen in the last 2 decades. So I think there is really a lot of hope for improvement in that. But that's the biggest thing. I think there are many other things. I think we, as physicians, need to take a much more holistic approach to women who have low-grade serous ovarian cancer. There's so many times the psychological issues are not well cared for, and women are struggling with those. But I'm excited about the clinical trial aspect, and I'm also I didn't mention really in the ICLC we're doing this Illuminate study that Dr. DeFazio from Australia is heading. And that's really going to be a deep dive into the molecular biology of low-grade serous carcinoma. So we're doing that, and out of those kinds of studies are going to come breakthroughs that will lead to better treatments. We're also doing a couple of other things briefly, and that is we're doing drug screens of hundreds of drugs against cell lines of low-grade serous ovarian cancer, and also these new antibody drug conjugates that are being tested, like mirvetuximab, are also going to be screened in low-grade serous ovarian cancer cell lines. So I think both in the preclinical laboratory basic science area as well as in the clinical area, we're going to see a lot more progress in the next decade than we've seen in the last 2 decades.
And my final question for you, thank you so much for that, is I think everyone's so incredibly grateful for the time and commitment and just the huge effort you've put into low-grade serous ovarian cancer. And there is, I suppose, awareness that you won't be able to eventually you're going to want to retire. And so I guess hopefully not for a wee while, but I guess what reassurance can you give to people in terms of the progress around who else is working in this field, both in terms of at MD Anderson and also the research field in regards to who you've trained up and
Yeah, there should be no concern. The ICLC group that I showed you 25 experts. They're going to most of them are going to be around much longer than I will. And they're gonna do great. At MD Anderson, we do have younger faculty that will take up the gauntlet to Dr. Cobb, Dr. Weston, others, because we have a faculty of about 25 gynecologic oncologists. So there's no lack of interest in this area at all. So I think women will be in very good hands. I hope to stay around for a while longer, and I'm not ready to retire quite yet. But there shouldn't be any concern at all.
Thank you. We're, yeah, honestly so grateful and very fortunate to have you in this community. And really I know, speaking to other researchers, they do say just how lucky we are in the low-grade serous community to have such a collaborative and supportive research environment and physician environment that isn't true for every disease, and how much really everyone's been guided by the example that you lead, which is just fantastic. So thank you so much for your time today, and for all of our listeners who have attended. I know that there were a lot more questions that people wanted answered that we just didn't have time for. And what I might do is just go through and select a few common ones, and then we might do a written response to some of those later on. But thank you so much, Dr. Gershenson, for your time, and we do really appreciate it.
Well, thanks for having me, and it's been a pleasure, and I hope it's been enlightening for people on the call, and just know that we're here to try to help. Thank you.
Thank you so much.